Moving to the last topic, that is binocular vision anomalies in kids, be dealt by Dr. SANITHA. She is a medical director of Vettam Eye Hospital, Puttota and Molandurthi, Ernakulam, and as well as performing as a pediatric ophthalmologist in multiple centers across Kerala. Over to you, ma'am.
Thank you, Anjana, and good afternoon, all of you. This is a relatively less discussed topic, so we wanted this in the IC because it is a very important one as far as the kids are concerned. Binocular vision anomalies affect coordination of the two eyes and disrupts optimal visual performance. So a child can have 6/6 and 6 vision, but at the same time child may have difficulties due to binocular coordination, and this can affect activities ranging from reading to navigation of complex environments. Binocular vision anomalies in children can be broadly classified as strabismic and non-strabismic. I'll not be talking about strabismic anomalies in this session. We'll rather touch upon more of non-strabismic ones, which again includes phorias, heterophorias, accommodative anomalies, and vergence anomalies. The whole point of the session is to prime ophthalmologists that there is something called non-strabismic binocular vision anomalies, and if we are cautious, if we are aware of it, we can actually guide them properly and give them much needed relief in their academic and other activities also. Accommodative dysfunction, we know it is results from difficulty in adjusting focus between the near and far distances. Convergence insufficiency is the inability to align the eyes properly when focusing on near. This is very common among children, and I'll be talking in detail about convergence insufficiency. As I mentioned, heterophorias are also included, and when there is disruption of fusion, there is a heterophoria, and this misalignment can cause visual disturbances. Binocular vision anomalies causes reduced visual efficiency. As I told, vision may be, as per the normal test, it might be normal, but the child has a reduced reading speed or gets asthenopic symptoms on regular activities. We should suspect some kind of binocular vision anomalies also. It can also cause occupational and social challenges. As I told, one of the most common and one of the most undiagnosed cause of visual efficiency problems in children is convergence insufficiency. So convergence insufficiency is a condition in which there is exophoria at near, orthophoria or low exophoria at distance, a receded near point of convergence, and reduced positive fusional vergence and low AC by A ratio. This might sound very technical, but in OPD also we can use some very crude test, I would say, like we are testing the convergence in this young girl. So as the pen comes close to the nose, okay, at this point you can see that one eye deviates outwards. That is because the subjective break point is when the patient is focusing on the tip of the pen. At one point the patient can have diplopia. That point is called subjective break point, and then the point at which you see the eyes deviating, that is the objective break point. This all of us do in our OPD, and it is a test for convergence testing. This is testing for the near point of convergence using an RAF ruler. So at one point when the patient is focusing on the dot with the line, the patient can experience diplopia, and then you can quantify it also, which will help us to assign the child as having normal convergence or abnormal. Similarly, accommodation can also be tested using the RAF ruler. We are all familiar with this. Sorry. This is something called positive fusional vergence, which again comes in the definition of convergence insufficiency. So base out prisms are used, and the patient is focusing on a near vision chart. You go on increasing the magnitude of the base out prisms, and at one point the patient's fusional Virgin's reserves are over, and then she will have diplopia. That is how you test for positive fusional Virgins. And heterophorias, these are latent deviations, and this present a small amount of squints, which are often missed in a usual OPD evaluation. But if the child has a normal visual acuity testing with asanopic symptoms, always look for a small phoria. It can cause all these problems. And AC by ratio, we all know about AC by ratio. It can be tested in cases for diagnosing convergence insufficiency. Again, convergence insufficiency is primary and secondary. Primary being not associated with strabismus or refractive errors, secondary those associated with these both. It is quite prevalent. There are studies which say 3 to 5% of population, 5% of kindergarten students do have convergence insufficiency. And as I told, they present with eye ache, frontal headache, fatigue, blurring of words, difficulty to concentrate, even nausea, dizziness, and more towards the evening, because throughout the day we are using our convergence reserves, and all these symptoms usually appear towards the evening. So this is also an important question which you can ask the child, what is the timing of the headache like. And symptoms are inversely related to the degree of convergence insufficiency, which means if the child has a large amount of problem, the child may not even try to attempt convergence, so they may not have the symptoms. And you have to ask for the duration of symptoms, time of onset, nature of work, previous work, and any medications. And also the general well-being, lack of sleep can actually aggravate the problems. And usually we get children coming at the time of exams. A lot of sitting through the night for studies can cause all these problems to manifest. There is something called secondary convergence insufficiency, because if you have a high refractive error, they may actually decrease the convergence ability. Also acquired myopia, so they do not have a need to accommodate for near. So therefore accommodative convergence is reduced. So how to manage convergence insufficiency? First and foremost thing, we do an appropriate refractive correction. And the next thing is we'll be talking about vision therapy. And the rationale behind the whole thing is, there is different components of convergence, out of which there is the fusional convergence reflex, which is plastic, which means fusional convergence amplitudes can be increased. But how do you do that? By challenging the binocular visual system in 2 ways. That is how you do vision therapy exercises. And basically you can improve the fusional convergence by using voluntary convergence to facilitate fusional convergence. That is what we do in pencil push-ups when we use a convergence card or a CAT card. Another way is by provoking the fusional convergence by stimulating disparate retinal elements. So we all do this test, but technically these are the principles behind this. We can use a base out prism to induce fusional convergence. So there are different therapy tools in convergence insufficiency, like a stereogram, base out prisms, Brock string, lifesaver cards, eccentric circles. So this is a convergence card. You can see the girl doing the exercise. And this is a Brock string, which works on the principle of physiological diplopia. This is a lifesaver card. This is the eccentric circles. This is a CAT card stereogram. So most of us actually, when you see a child with a small heterophoria, most of us tend to diagnose it as convergence insufficiency. So I would like to say that not all small heterophorias or exotropias are convergence insufficiency. So because if you treat a convergence insufficiency with the proper exercises, they definitely will improve. And what kind of exercises do you give? This is the classical one which we give, pencil push-ups. So the most important thing when you advise pencil push-ups is that you have to advise them properly. The patient will have a lot of problems because of this esthesionopia, and whatever you convey to the patient, they will be doing it. So it's our responsibility to do it properly. I say this because most often it's not done properly. It's a very simple thing. So just see the video. This is a cat card exercise being done. So this is the cat card stereogram in which you have two incomplete cats, one with the tail and whiskers and other without. So this is held at a distance and the patient is looking at the tip of a pen which is kept midway between the card and the patient. So the basic exercise is bringing the pen closer to your nose and trying to focus only on the tip of the pen. Okay, and at no point we are looking at the cat card. We are looking only at the tip of the pen and we are trying to see the cat on the cat card stereogram as a single cat with whiskers and tail. Okay, this is important because what we are basically doing is we are keeping the accommodation at check and accommodation at stable distance, and then we are using convergence to may improve our convergence facility. That is how you treat it. Just see the video now. Okay. Now bring the tip of pen closer and look only at the tip of the pen. All these times she was seeing the cat as 2. Okay. Yeah. At this point she says that she is seeing it as double, and when you she was seeing it a single, and when you see it single you hold it there for a few seconds, and then that is basically you are keeping your accommodation distance constant, and you are using only your convergence to see the cats. So that is how you do a proper cat card exercise. And then you can again don't blink because again that automatic correction happens. Never look at the cat stereogram, only look at the tip of the pen, and then you have to fuse using your convergence to see the cats as single. So this is actually this is similar to pencil push-ups, but we are having a target here also. So this is more recommended. So maybe you can see the video once again. Okay. Now it is single, and hold it for some time, and again then you can do the exercise maybe 5 times or 10 times depending upon the patient's state of convergence insufficiency. So ask the patient to do the exercise when the patient is fresh. So after all the work of the day, if you are trying to do it in the evening, they will have more problems. Actually it will induce headaches. So once it is done properly, it will have a lot of very promising results, and there are a lot of patients coming to our OPDs with convergence insufficiency, and if you understand it properly and convey the right message, all these people can be treated very well. But at times what happens is patient will be doing like this, and what we improve is our biceps actually, not the convergence muscles. It is usually the conveyance of this is very different. So that is one take-home point which I wanted to convey. And now there are a lot of home therapy system tools also which uses accommodation and convergence exercises. This can be done in office or at home also. So these are also very efficient in improving convergence insufficiency. So I have just mentioned about the most important and most clinically relevant one, convergence insufficiency. There are other things like especially because of the smartphone use and by children, there are a lot of problems with accommodation also, but I think it would be a too lengthy presentation to present all that. That's all. Thank you.